You get assessment of the audiovisual facilities and the translation. I'm going to collect this overall assessment of the course together with assessment of the lectures until this lecture to do the statistical analysis. There will be remaining some other lectures. This could be collected tomorrow. Please don't forget. This is a collection of the diagnosis of upper urinary tract obstruction, and this is a review article. It was published in the British Journal of Urology International. We are going to start with a clinical presentation in terms of symptoms and signs. For the symptoms, it has a wide range of no symptoms at all, to the other extreme of acute renal colic necessitating admission to the hospital. What are the factors that affect the degree of acute renal colic? This depends upon the degree of obstruction, whether it is complete or partial, the time interval, whether it is acute or chronic, the etiology of obstruction, whether it is intrinsic, that is to say inside the kidney, or extrinsic, that's to say outside the kidney and ureter, and also it depends upon the laterality, whether the obstruction is unilateral or bilateral. This is regarding the symptoms. What about the signs? Also, the signs have a wide range of no signs at all, and this is the most common, to the other extreme of abdominal mass that is felt clinically, clinical hydronephrosis, volume overload, and acute renal failure in terms of azotemia. These are the items of radiological diagnosis of upper urinary tract obstruction, IVP, ultrasound, renogram, spiral CT, magnetic resonance urography, Whittaker test, antegrade, and retrograde studies, and we are going to go through these items in some details. Starting by the IVP. IVP is still the gold standard for detection of urethral obstruction in patients having normal renal function, no allergies, and not pregnant. All of us are aware of the normal IVP. This is the right kidney, this is the left kidney. These are the upper group of calyces, middle calyces, lower calyces, renal pelvis, ureter, and bladder. This is a normal IVP. What are the signs on IVP of acute obstruction? Number one, there could be an obstructed or persistent nephrogram. This means that the dye is entrapped inside the kidney, and the kidney is not able to excrete the dye. Therefore, the kidney will appear like a big piece of bean, white in color. This is due to entrapment of the dye inside the parenchyma of the kidney. Another sign of acute obstruction is delay in the filling of the collecting system. You may inject the dye today, and the kidney may not excrete the dye even after 1 or 2 days. We call it delayed excretion of dye. Another sign is dilatation of the connecting system, and a fourth sign is possible rupture of the fornix with extravasation of urine outside the kidney. I'm going to give an example of each of these radiological signs on IVP to make it easy. This is an example of persistent nephrogram. You see, here is the kidney, the right kidney. It appears white in color. Why? Because of entrapment of the dye inside the parenchyma. The parenchyma is not able to excrete the dye to the pelvic calcium system. And this is an example of delayed excretion of dye by the left kidney. This would be after 2 days of injection of radio contrast material. This is another example of no excretion of dye at all. Here, this is a normal right kidney, and here, because of acute renal colic, there is no excretion of dye by the left kidney. This is an example of rupture of a fornix. The minor calyx is ruptured, and the dye is extravasated outside the kidney. This is a sure sign of acute obstruction. Then for chronic obstruction, what are the signs on IVP of chronic obstruction? Urethral dilatation and tortuosity. The ureter becomes dilated and tortuous above the level of obstruction. A standing column of contrast material in the ureter to the point of obstruction, and the kidney may demonstrate marked parenchymal thinning, and we are going to give an example of each of these signs to make it easy. This is an example of marked right hydroureteronephrosis. I'm sorry. This is an example of marked hydroureteronephrosis on the right side due to a stone here on the pelvic part of the ureter. You see here dilatation of the kidney and dilatation and tortuosity of the right ureter down to the level of obstruction. Now we finished the first item, which is the IVP. We are going to discuss the next item, which is the ultrasound. The ultrasound is very important in the diagnosis of obstructive uropathy, and there are several modalities of ultrasound to diagnose obstructive uropathy. Number one, which is the most common to work with, is the grayscale ultrasound. Then diuretic ultrasound. Diuretic ultrasound, then Doppler ultrasound. This includes renal resistant index and ureterogen, and then combination of several items together, combined together, we call it ultrasonographic multivariate scoring system. So we are going to start with the grayscale ultrasound. This is the normal kidney. You know that the landmarks is, this is the renal capsule. Why it is bright white? Because of fat around the renal capsule. And this is the pelvic cell system. It is also bright white because of fat and because of blood vessels. And these black dots inside the white area, these are the calyces and the renal calyces. And between the white of out and the white of in, this is the renal parenchyma. And a perfect or expert ultrasonographer, he can give you a picture of ultrasonography that can differentiate between the cortex and the medulla of the renal parenchyma. And here is a normal other kidney. The ultrasound, grayscale ultrasound, can visualize a stone in the calyces, in the pelvis, in the upper part of the ureter, and in the lower part, the lower end of the ureter. This area, in the middle part of the ureter, is blind by the ultrasound. Ultrasound has two elements, bone and the gas. So the middle part of the ureter is here. There will be anteriorly in front will be the intestine, which is full of gas, and posteriorly there will be the iliac bone. Therefore, this area is blind by the ultrasound. Ultrasound, we can see stones in the pelvis, here, calyces, uppermost part of the ureter, and the lowermost part of the ureter. This is an example of multiple stones in the middle and lower calyces, and we can observe that the stone appears white, and there is acoustic shadow. Acoustic shadow means shadow which is black in color. This is reflection of the ultrasound waves. And here, this is a stone, example of a stone, will be visualizing in the upper part of the lumbar ureter, and another stone in the lowermost part of the pelvic ureter. So these are the sites where the ultrasound can see stones. But in the middle part of the ureter, it is blind by the ultrasound because of bone and the gas. Then, the ultrasound can see the stone itself, but sometimes the ultrasound can see the effect of the stone. Cannot see the stone, but can see the effect of the stone. What will be the effect of the stone is dilatation of the pelvic calcium system. We call it pyelocalyctasis. However, this approach is neither sensitive nor specific. Why it is not sensitive? Because there is a false negative results in 20 to 30% of patients. What does it mean? This means that in about 1/3 of cases with acute renal colic, there is no dilatation of the pelvic calcium system. Why? Because in acute obstruction, there will be no sufficient time for the pelvic calcium system to dilate. Why it is not specific? Because the pelvic calcium system can dilate in conditions, other conditions, rather than obstruction. The obstruction is not the only cause of dilatation of the pelvic calcium system. What are the other causes of dilatation of the pelvic calcium system? These include pyelonephritis, vesico-urethral reflux, residual dilatation, residual dilatation after relief of obstruction, and overdistension of the pelvis. So in all of these conditions, there will be dilatation of the pelvic calcium system, but without obstruction. So I repeat again, the approach of pyelocalyctasis or dilatation of the pelvic calcium system by the grayscale ultrasound is neither sensitive nor specific. It is not sensitive because in about 1/3 of cases with acute obstruction, there may be no dilatation of the pelvic calcium system. Why it is not specific? Because obstruction is not the only cause of dilatation of the pelvic calcium system. There are some other causes that can dilatation of the pelvis and the calyces, including pyelonephritis, vesico-urethral reflux, residual dilatation after relief of obstruction, and over-distension of the urine. This is an example of mild degree of dilatation by the ultrasound, moderate degree of dilatation or moderate degree of hydronephrosis by grayscale ultrasound, and the marked degree of hydronephrosis by grayscale ultrasound. Now, we finished the grayscale ultrasound. There are other modalities, we call it diuretic ultrasound. What does it mean, diuretic ultrasound? We do grayscale ultrasound, then we inject a diuretic, we inject vases, and then we see how the pelvic calyceal system will become dilated. And after a time, we measure the time where the pelvic calyceal system returns back to the baseline of the pelvic calyceal system. This is the diuretic ultrasound. We do ultrasound at baseline. We do ultrasound, grayscale ultrasound on the baseline, then we inject the diuretic, and we see how the pelvic calyceal system becomes dilated, and we measure the time where the pelvic calyceal system returns back to its basal condition. So it is expected that in obstructive uropathy, after injection of a diuretic, there will be marked dilatation of the pelvic calyceal system, and the time lag between dilatation to returning back to the baseline will be prolonged. But this approach is not objective because the degree of dilatation is not precisely determined, and also the time where the pelvic calyceal system needs to return back to the baseline is not also precisely determined. Therefore, this approach is localized or is used only in pregnant ladies where you are obliged to use ultrasound because you cannot use IVP, you cannot use CT for diagnosis. There is another type of ultrasound, we call it Doppler ultrasound. The first item of the Doppler ultrasound is to measure what we call renal resistive index. What is renal resistive index? These are index. This is some sort of measurement of velocity of the blood inside the blood vessels, inside the arteries, the interaortic arteries of the kidney. Obstructive uropathy will make hemodynamic changes. So the velocities of the blood will be changing, and then this will result in increase of the renal resistive index. The renal resistive index is defined as peak systolic velocity minus end diastolic velocity divided by peak systolic velocity, and chronic obstruction, the renal resistive index is more than 0.7. This is an example of Doppler ultrasound. This is the gray ultrasound. You see that there is dilatation of the kidney, and these lines are the peak systolic velocity. The peak of every is the peak systolic velocity, and this line is the end diastolic velocity. The computer will automatically make calculation of renal resistive index by peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity. The normal value is 0.7. In cases of obstruction, renal resistive index increases above 0.7. We have several international publications in this, and I got a PhD from Erasmus University in the Netherlands regarding the role of renal resistive index in obstructive uropathy. However, some false positive results the renal resistant index can increase not only in obstructive uropathy, but also in other conditions rather than obstructive uropathy. This includes children, renal medical disease, dehydration, hypotension, and low heart rate. However, a normal renal resistant index in these conditions is still a strong argument against obstructive uropathy. So if you have any of this, and then you measure the renal resistant index and you find it in the normal range, 0.7 or less, this means absence of obstruction. So it is a good negative test. How to increase the diagnostic accuracy of renal resistant index? We inject a diuretic, we call it diuretic renal resistant index. The injection of the diuretic will cause changes of the hemodynamics of both kidneys, so that the renal resistant index of the normal kidney will get decreased, and the renal resistant index of the obstructed kidney will increase. So there will be a divergent response. Normal kidney decrease, obstructed kidney increase. So we make the difference between normal minus obstructed minus normal renal resistant index, renal resistant index of the obstructed kidney minus that of the normal kidney. This is, we call it delta resistant index. Delta resistant index. This is the resistant index difference between the obstructed minus the normal. And this is the range. It ranges between 0.06 to 0.1. This is the normal range. If it is more than this means obstruction. Another approach is we calculate the renal resistant index ratio. What does it mean? Resistive index of the obstructed divided by resistive index of the normal kidney. We call it RIR ratio, renal resistive index ratio, and the normal range varies between 1.1 to 1.15. If it is more than this indicates the presence of obstruction. So an approach to increase the value of renal resistive index is to inject a diuretic. It will cause renal resistive index of the normal kidney to decrease and the renal resistive index of the obstructed kidney to increase. This is a divergent response. This will facilitate the diagnosis. We can calculate the delta resistive index, which is resistive index of the obstructed minus that of the normal. And this is the range up to 1.1, or resistive index ratio, the resistive index of the obstructed divided by resistive index of the normal, and if it is more than 1.15, this indicates obstruction. However, this approach is not applicable to patients with bilateral obstruction or obstruction of the solitary kidney. This is very important in acute obstruction. The previous information were about chronic obstruction. For acute obstruction, a resistive index, delta resistive index of more than 0.04 is diagnostic of acute obstruction. And in pregnancy, we have limited tools to diagnose obstructive uropathy. There is a physiological dilatation of the pelvic cell system due to hormones of pregnancy. There would be normal dilatation of the pelvic cell system. Therefore, grayscale ultrasound with demonstration of dilatation of the pelvic cell system is not an accurate approach to diagnose obstruction. Also, IVP and the CT are contraindicated. Therefore, delta resistive index is of particular interest. What is delta resistive index? This is resistive index of the obstructed or the resistive index of the kidney suffering from pain minus that of the other side of normal kidney. If it is more than 0.04, this indicates presence of obstruction. This is of particular value in pregnant ladies, and I have a very important publication, and this concluded that delta resistive index is a sensitive and a specific test that can replace IVP in the diagnosis of acute unilateral ureteric obstruction in pregnant ladies, and this is very important reference. Then, what is the other approach of the Doppler ultrasound to diagnose obstruction? What we call ureteric jet. What is ureteric jet? You know that the urine is coming from the ureteric orifice by peristalsis, and it goes from the orifice to the bladder by jet, like ejaculation, not passively by gravity. So an approach to diagnose obstructive uropathy is to put the Doppler ultrasound on the bladder, and then you observe the jets of urine coming from both ureters, both ureteric orifices. This is very important in case of unilateral obstruction. You have to compare the obstructed versus the non-obstructed side. In case of acute complete obstruction, there will be no jets at all. One kidney is, or one ureter is giving jets, and the other one, there is no jets at all. In case of incomplete obstruction, the side of incomplete obstruction will give the number of jets compared to the normal one becomes decreased. And this is the figure of the ureteric jet on the right side from the ureteric right orifice, and this is the figure of the jet from the left ureteric orifice. However, this approach also is difficult and demanding because you have to put the Doppler ultrasound probe over the bladder and wait maybe for 15 minutes to calculate the jets, number of jets in the obstructed compared with the number of jets from the non-obstructed side. But it is very important in pregnant ladies, because in pregnant ladies you have limited tools. You have to use grayscale ultrasound, diuretic ultrasound, or Doppler ultrasound. Then this ultrasonographic multivariate scoring system, this scoring system gives seven factors for scoring or diagnosis of obstructive uropathy. These factors include 3 factors related to the parenchyma of the kidney: increased echogenicity of the parenchyma, parenchymal thickness, thinning of the parenchyma less than ½ centimeter, and hypertrophy of the contralateral kidney. These 3 signs are signs of obstruction found in the kidney. And there are 2 other signs related to the resistive index ratio more than 1.1, and delta resistive index more than 0.07. And then 2 other factors related to the ureter, which is a dilated ureter more than 1 centimeter, and the absence of peristalsis of the ureter. So these 7 factors, we call it a scoring system for diagnosis of obstructive uropathy. They make combination of several factors to diagnose obstructive uropathy for optimization of the use of the ultrasound in the diagnosis of obstructive uropathy. Then what about the renogram? The renogram could be used for diagnosis of obstructive uropathy in one of 4 ways. Number 1 is measurement of the standard diuretic renogram curve. Number 2, measurement of half-time drainage or T-half. Number 3, furosemide -15, F-15 diuretic renogram. And number 4 is measurement of individual renal function over the follow-up period. We are going to go through in each of these items in some details. The first is the standard diuretic renogram. This is designed by Orielli in 1976. These are the 4 patterns of the standard diuretic renographic curve. This is the normal pattern. When you inject the radioisotope, the radioisotope will accumulate, increase until the summit. And when you inject furosemide or lasix, then the radioisotope will go rapidly. The kidney will drain the radioisotope rapidly. So this is the normal pattern. Here is the obstructed pattern where you inject the radioisotope, it will accumulate, increase, and when you give the lasix, it is continues to increase. So there will be progressive increase, and the curve is going up. So this is the obstructed pattern. Here is the dilated non-obstructed pattern where when you inject the radioisotope, it will accumulate, then reaches the summit, and the summit will be prolonged like that. There will be a long time where the radioisotope is reaching up in the kidney, and when you inject the furosemide, it goes down. This is the dilated non-obstructed. And here is the equivocal pattern. The curve neither go down nor go up. And this is the shape of the curve. Here, this is a live demonstration. Here, one kidney, and the other kidney. This is the normal curve. It will be like that. Here is the red one. Here is an obstructed kidney. The curve is going up. This is an obstructed kidney. Here is a dilated non-obstructed where the curve goes up and then is sustained in the summit for a long time and then goes down. This is dilated non-obstructed. And here it is equivocal curve, neither go down nor go up. So there are 4 patterns of the radioisotope radiographic curve. Normal, obstructed, dilated, non-obstructed, and equivocal. Then the next item for the renogram is half-time drainage. Half-time drainage, or T-half, it is the time necessary for half of the radioisotope to be eliminated from the renal pelvis. Normally it is less than 10 minutes. If it is more than 20 minutes, it is obstructed. If it ranges between 10 to 20 minutes, it is equivocal. What are the limitations of using the standard diuretic renogram and the half-time drainage in the diagnosis of obstructive uropathy? These 2 items may be misleading in neonates because of immaturity of the glomeruli. Therefore, the response of the kidney of an infant or young child is blunted. It is weak response to lasix. And also it may give a false positive result in dilatation of the critical cell system. The glomerulofiltration rate is less than 15 milliliter per minute, and in case of deregulation. So these are the limitations of the standard diuretic renogram and half-time drainage. To overcome this limitation, there is what we call furosemide minus 15 or F minus 15 diuretic renogram. What does it mean? The normal diuretic renogram, we call it F plus 20. What does it mean? F means the furosemide, plus 20 means that we inject furosemide 20 minutes following injection of the radioisotope. F plus 20. This is the normal. But in case of hugely dilated pelvic cell system, if you do that, there will be no sufficient time for the radioisotope to fill the dilated system. Therefore, we inject furosemide 15 minutes before injection of the radioisotope. F minus 15. Why 15 minutes? Because furosemide reaches its maximum effect after 15 to 18 minutes. So if you inject the furosemide 15 minutes before injection of the radioisotope, then the pelvic cell system will become filled with urine because 15 minutes passed. Then you inject the radioisotope. So this will overcome the limitation of diagnosis of obstructive uropathy in hugely dilated system, or if the glomerular filtration rate is less than 15 milliliter per minute. Then the last item is measurement of individual renal function. Sometimes you did all of these tools of renogram and you didn't get answer whether this kidney is obstructed or not obstructed. What are you going to do is to do follow-up of the selective renal function over time. Every 3 minutes, you repeat the radioisotope renography and you see the selective renal function. If there is progressive deterioration of the suspected kidney, this is a sure sign of obstruction. But if there is a stabilization or improvement of the selective function of the suspected kidney, this means absence of obstruction. So this is the last tool to use radioisotope renography in the diagnosis of obstructive uropathy. Then the next item is the spiral CT. The spiral CT could be used either in acute obstruction, we use non-contrast CT, or in chronic obstruction, we use CT with contrast. For non-contrast CT in diagnosis of acute obstructive uropathy, it is very sensitive and very specific. It has the advantages of no injection of radiocontrast material, visualization of a small radiolucent stones that could not be visualized by the KOB or IVP. It is a very fast procedure, taking only a few minutes, and also it can identify other urinary and non-urinary abnormalities to direct further imaging and management. This is an example of non-contrast CT showing a stone in the renal pelvis. Another example here, a stone in the right iliac ureter. Here, a stone in the right lumbar ureter. And regarding interpretation, the non-contrast CT can see all types of stones regarding their chemical composition, except only one type, which is the NEPHROLOgy stone. NEPHROLOgy is the drug used for treatment of HIV patients, and it gives some sort of mud in the kidney, which is totally free of calcium. So this is the only type of stones that could not be visualized by non-contrast CT. Other types, all types, whether if it is even not seen by the KOP or IVP, could be seen clearly by non-contrast CT. And if you cannot see the stone, there are some secondary signs of obstruction. Signs that indicate presence of obstruction, like ureteric and renal dilatation, stranding of the perinephric fat, perinephric collection, soft tissue ring sign, and the pale kidney sign. We are going to give an example of each of these to make it easy. Here is perinephric stranding of fat. The fat is separated here from the left kidney. And here is right perinephric collection. Here is a collection around the right kidney. And here is soft tissue ring sign. Why it is ring sign? The ring here, this is my finger. The finger is the stone, which is bright white. And the gray zone is the ring, because of edema of the earth. So here is the stone, bright red. This is my finger, and here the gray one, this is the edema around the ureter, which is the ring. We call it soft tissue ring sign. These are the pitfalls that can make false interpretation with non-contrast CT, which is pelvic filibuli can be mistaken with the stones and the pelvic part of the ureter, and the dilatation of the gonadal veins. This could be confused with dilated ureter. This is an example of pelvic filibuli. Pelvic filibuli, yes, filibulith, and filibuli multiple. This means this calcification of blood vessels inside the true pelvis. This could be mistaken as the stones in the pelvic part of the ureter. However, what are the disadvantages of non-contrast CT in acute obstruction? There is no evaluation of renal function. There is no evaluation of the urothelium. It is a relatively expensive procedure. It exposes the patient to high radiation. Therefore, it is contraindicated in pregnant ladies. It needs a special training in the interpretation of the figures, and it is not universally available. Then, for chronic obstruction, we can use CT with contrast. We published an article comparing 130 kidneys for whom we did CT with contrast for anatomical and assessment and selective determination of glomerular filtration rate of both kidneys. And we compared this to the gold standard of IVP and radioisotopography, and we concluded that contrast CT is more sensitive than IVP in diagnosis of the cause of chronic obstructive uropathy, and also it is as accurate as radioisotope renal scan in the calculation of total and selective renal function. So, CT with contrast is not only useful to diagnose obstruction, but it also useful to do measurement of the selective renal function of both right and left kidneys, like that of the radioisotope renography. We call it dynamic CT. So CT with contrast can diagnose obstruction, and also it can assess the selective renal function of the right and left kidney. We concluded that we recommend the spiral CT with contrast as a single radiological diagnostic modality for the assessment of patients with chronic renal obstruction and normal serum creatinine. This is an example here. There is no excretion of dye by the left kidney on IVP, but the CT can visualize the right kidney, dilated kidney, and ureter, a stone in the lowermost part of the ureter. Another, here there is no excretion of dye by the right kidney, but by CT you can see dilated kidney, dilated kidney. However, the CT has limitations, could not be used in cases of renal impairment, in pregnant ladies, and in patients having allergy to radiocontrast material. Then what about MRU, magnetic resonance urography? It has been shown that the static column of urine in the dilated urinary tract is easily visualized by T2 weighted magnetic resonance urography as a bright white column, but without injection of radiocontrast material. So MRU is indicated if there is contraindication to IVP, where there is allergy or pregnancy or renal impairment, or failure of IVP to reach diagnosis like no excretion of dye, persistent nephrogram, poor excretion of dye, or no different diagnosis. The advantages of T2 weighted magnetic resonance urography: there is no injection of contrast material, there is no exposure to ionizing radiation, it is a non-invasive procedure, and it can save the patient invasive procedures like antegrade and retrograde studies. I published an article that concluded that CT gadolinium enhanced T1 weighted MRU is as accurate as radioisotoprenography in the calculation of the total and separate kidney function. So please note that MRU, we call it dynamic MRU, not only used in the diagnosis of obstructive uropathy, but it can also be used for assessment of the selective renal function, like radioisotoprenography. We call it dynamic MRU. So this is the diagnostic value of MRU in obstructive uropathy. It can accurately identify presence of obstruction, degree of obstruction, level of obstruction. However, for the diagnosis of the cause of obstruction, if the cause of obstruction is stones, it is not accurate. Cannot see stones accurately. But if the cause of obstruction is due to causes rather than stones, it is accurate in diagnosis of non-calcular obstruction. Also, it could be used for evaluation of the total and the selective renal function. And here we can, you can see that the MRU can have an overall sensitivity of 90% for diagnosis of non-calcular obstruction in terms of ureteric stricture, tumors, and extrinsic obstruction. This is an example of T2 weighted MRU where there is marked dilatation of the ureter down to the lowermost part of the ureter. Another example, marked dilatation of the kidney ureter due to a stricture in the lower end of the ureter. This is without injection of any contrast material. This is T2 weighted MRU. This is the column of urine. It appears white without injection of any contrast material. And here, this is a retroperitoneal fibrosis causing bilateral hydronephrosis with medialization of both ureters. For the Whittaker test and the antegrade and the retrograde studies, Whittaker test means that you fix percutaneous nephrostomy, and the percutaneous nephrostomy has two ends. One end having something to measure the sensor to measure the pressure inside the kidney, and the other end will allow passage of saline with gravity. So you allow passage of saline with gravity over the percutaneous nephrostomy, and the percutaneous nephrostomy will have a sensor to measure the pressure inside the kidney. If it is more than 20, it is obstructed. If it is less than 10, it is non-obstructed. If it is between 10 to 20, it is equivalent. However, this approach is invasive one because it needs fixation of percutaneous nephrostomy. The other approach is the antegrade approach. You fix percutaneous nephrostomy and you inject a dye to see the pelvis and the ureter. And the other approach is to do retrograde pylography by fixation of ureteric catheter up to the ureter and the injection of dye. However, this approach is an invasive procedure because it needs either fixation of the percutaneous nephrostomy or doing cystoscopy with fixation of ureteric catheter. So I'm going to conclude. For acute obstruction, if you have a patient with acute flank pain, you do clinical evaluation. If it is non-suggestive of a stone disease, you go directly to non-toxicity. If you diagnose a stone, you plan treatment. If the stone is absent, you do further work up, assuming the stone disease is absent. But in patient with flank pain, and you do clinical evaluation, and it is suggestive of a stone disease. For example, patient has a past history of repeated attacks of renal colic, past history of stone passage, past history of endoscopy or open stone surgery. Then you do KUB, plain X-ray, grayscale ultrasound with Doppler ultrasound. If the stone is present, you plan treatment. If the stone is absent, you do non-contrast CT. If the stone is present, you plan treatment. If the stone is absent, you do further workup, assuming stone disease is absent. So in this algorithm, we combined all the diagnostic tools in one slide. Then, on the other hand, in cases of chronic obstruction, the hallmark of chronic obstruction is dilatation of the pelvic cell system by the ultrasound. You start by non-contrast CT. If a stone is present, you plan treatment. If a stone is absent, you do renogram together with renal resistive index. If there is no obstruction, you do follow-up. If you have obstruction, you measure serum creatinine. If you have normal serum creatinine, you do IVP. If IVP is conclusive, you plan treatment. If IVP is not conclusive, you do CT with contrast. But if serum creatinine is high, you do magnetic resonance urography. If it is conclusive, you plan treatment. If it is not conclusive, you do retrograde and antegrade studies. So also this slide combined all diagnostic modalities in one slide. Now I'm finished.